Thank you, sir, and thanks organizers for giving me the opportunity to speak on experience sharing in extensive stage lung cancer regarding durvalumab. Most of the experience we have in maintenance locally advanced non-small cell lung cancer. I have two patients. I have given durvalumab in two patients, uh, and the result is good till now. The number is very small, but still, whatever experience we have. So today I'll present a case where durvalumab was given along with the various evidence of durvalumab in extensive stage, as well as what are the recent guidelines. So, okay. This is 35-year-old gentleman, Mr. X, who presented in June 2020 with a chief complaint of a change in voice, which is slowly progressed to aphonia dysphonia
Dr.
with
Saini,
no
your
call.
slides are not moving, and make it on presentation
Is
mode.
it is it is it it is not moving?
Tarun, can you see? I can't see the moving.
Yeah, so please make it as a full screen.
I have already made it in full screen. Just a minute.
So kindly reshare your slides, sir. Just remove.
Okay.
Yeah, stop sharing, then start sharing again.
Sure. Now is it in full mode, presentation mode?
No, I think so.
No, sir.
Can you, the organizer can, share from their side?
Sir, we don't have Dr. Rajeev slides.
So proceed by this, sir. We can see anyways. We can see your slide. You can just
Okay. Now make it a
You're just scrolling,
full
yes.
presentation mode. Now we can
Okay.
see.
Okay. So is it in in presentation mode or not, sir?
No, you proceed with this only. It's okay.
Okay, thank you. Okay, so sir, please confirm whether slides are moving or not.
Okay, go to the next slide.
Is it moving?
No.
Okay.
No, it's not moving. Earlier it was, sir.
Now?
Yeah. Now it is moving.
Okay. So I'll start again. So this is 35-year-old gentleman, Mr. X, who's presented in June 2020 with a chief complaint of change in voice, which was slowly progressed to aphonia, dysphonia with no comorbidity and smoking history also. Initially, patient presented outside in ENT department where he was diagnosed with vocal cord palsy, and for I think 2 months nothing was done. He underwent full scan in August 2020, where there was a multiple enlarged conglomerated necrotic lymph node in hilum, paratracheal, and paraesophageal region, and also in aortopulmonary window forming nodal mass comprising left pulmonary artery. And there is small, mild enhancing soft tissue with surrounding fibrosis in left apical segment. Based on this report, no biopsy was done, but patient was started on ATT. Patient took ATT for around 1 month. His condition worsened, and patient, when presented to us, he presented with a history of seizures in September, and started on anti-epileptic drug. And after around 15 days, he presented to us. Uh, he presented in September, end of September. Then we have done MRI brain, where it shows 2 into 1.9 into 1 centimeter size right temporal lobe lesion with mild surrounding edema and multiple subcentimetric size lesion in bilateral temporal and left frontal parietal occipital lobes. And then HRCT was done at that time, which shows upper lobe lesion with mediastinal extension and encasement of left pulmonary artery, mediastinal lymph node, and consolidation in left upper lobe. So PET scan was done, and it shows left hilar mass with bilateral mediastinal nodes. So this was done on 28 October after and basically these are two scans. One is a baseline scan and other is after treatment. So we'll discuss the scan later on. And in this scan, we have this bilateral cervical. This is left is cervical nodes as well as bilateral paratracheal nodes. The biopsy was done, and histopathology shows small cell neuroendocrine carcinoma. PDL1 shows TPS score of 3 to 4%. So the patient was diagnosed as extensive stage small cell lung carcinoma with brain metastasis. So whenever patient presented to us with brain metastasis, we have always have confusion whether we start with chemotherapy first or with brain radiotherapy, or with chemotherapy plus immunotherapy upfront. So this is the paper which shows how to treat brain metastasis in extensive stage small cell lung cancer. And the key conclusion in the study was whenever patient is asymptomatic and having brain metastasis at baseline, chemotherapy alone is the most commonly recommended first-line treatment. And in asymptomatic patient with limited volume brain metastasis, higher preference for chemotherapy without WBRT. But in symptomatic patient, we should start with WBRT followed by chemotherapy was recommended most commonly. And however, in symptomatic patient with limited extent of brain metastasis, you can start with SBRT as an alternative to WBRT. And even if we see the NCCN guidelines also, it also recommended that in asymptomatic patient, you can start with systemic therapy followed by a brain RT after completion of induction systemic therapy, or in symptomatic patient, you can start away with brain RT before systemic therapy or concurrent with systemic therapy also. So the chemotherapy, the standard chemotherapy in extensive stage small lung cancer is etoposide and platinum-based chemotherapy, and we can see that median PFS with this therapy was around 4 to 5 months, and median overall survival is less than 1 year, around 9 to 10 months. So the patient was initially started on etoposide and cisplatin-based chemotherapy. After giving first cycle chemotherapy, on 4th day we have started a patient on radiation therapy. Whole brain radiation therapy was given with hippocampal sparing and followed by 9 gray 3 flexion to gross regions. So basically, there are two immunotherapy drugs which was approved in extensive stage small cell lung cancer, that is durvalumab and atezolizumab. Durvalumab was approved in March 2020, and since this patient was ECHS beneficiary, we have given the option of durvalumab and started him with third cycle of chemotherapy. Durvalumab was added, and it was given at a dose of 1500 milligram every 3 weeks with chemotherapy. Then after chemotherapy, maintenance immunotherapy was given every month, that is every 28 days. So what is the rationale of addition of immunotherapy with chemotherapy? It was found that chemotherapy have enhanced the effect of immunotherapy as they have synergistic effect. It was seen that chemotherapy induced tumor cell killing, which induce tumor antigen release and exposure to immune system, and PD-L1 overexpression leads to immune cell invasion and T cell invasion. So by the use of immunotherapy, this PD-1 PD-L inhibition restore tumor specific T cell immunity, and this reversion of immune suppression leads to deeper, more durable systemic anti-tumor response. So the trial, the durvalumab-based trial, that is Caspian, is the first and only approved immunotherapy regime in extensive stage small cell lung cancer to allow up to 6 cycles of etoposide platinum in control arm and use of cisplatin or carboplatin in practice with the real life practices. So in this study, the patients were randomized between etoposide cisplatin versus etoposide cisplatin with durvalumab. Primary endpoint was overall survival, and key secondary endpoint was PFS, overall response rate, overall survival at 18 months, and PFS at 6 and 12 months, and health-related quality of life. The Caspian allowed for investigator choice of platinum-based chemotherapy, whether you can use cisplatin or carboplatin, and even patients who are asymptomatic brain mets or brain mets which was treated were allowed to participate in this trial. And the control arm allowed up to 6 cycles of chemotherapy, and the prophylactic cranial irradiation were at investigator discretion. So this study is slightly different from the atezolizumab study because Caspian study inclusion criteria is reflective of real-world clinical practices, which allow treatment with either cisplatin or carboplatin, and also include the patient with either asymptomatic untreated or treated brain metastasis, compared against up to 6 cycles of chemotherapy with optional PCI. So salient aspect was already described. Now the overall survival. And one important thing regarding the use with the use of durvalumab also, irrespective of brain metastasis, normally the patient who presented with baseline brain metastasis overall survival was less. But when immunotherapy was added, the difference is much lesser. You can see that with brain metastasis, overall survival is around 12 months, and without brain metastasis, the overall survival is 13 months in immunotherapy group. And if we see chemotherapy group, it was 8.8 months in brain metastasis and around 10.5 months without brain metastasis. So durvalumab consistently improved OS versus EP in patient regardless of the presence of baseline brain metastasis. And regarding progression-free survival, median PFS in both arms is around 5 months, but at 6 months the PFS is progression survival rate is similar. But when we see PFS at 12 months, 18 months, and 24 months, it changes dramatically. More than 3 times the number of patients were progression free at 12 months, and nearly 4 times the number of patients were progression free at 24 months with use of durvalumab. And around 10% of patients were continuing treatment with durvalumab at 3 years.
My apologies. Just left 1 minute to conclude your presentation. Thank you.
Okay. And if we see about the overall survival, it is 13 months versus 10.5 months, and then we can see at 1 year OS, that is 52% versus 39%. 2 year survival is 23% versus 14%. 3 year survival, that is 3 times more patients were alive with durvalumab at 36 months. And if we see the subgroup analysis also, all the subgroup, whether patients are younger or older, whether male or female, whether they have smoking status or not, whether baseline brain metastasis is there, all group were benefited with the addition of durvalumab. And regarding durvalumab is the first approved immunotherapy drug to improve both response rate and durability of response at 24 months. That is 13.5%, more than 3 times more patients remaining in response at 24 months with durvalumab versus chemotherapy alone. The follow-up PET scan was done after 3 cycles of immunotherapy, and after 6 cycles of chemotherapy and 3 cycles of immunotherapy, and the patient was continue on complete remission even after extended number of cycles. So the durvalumab is the only IO with clinical trial data supporting 4 weekly maintenance dose administration scheduled for extensive stage, which was easier for patient to and having good and lead to good compliance. And it is also more cost effective versus chemotherapy alone or with as compared to atezolizumab. It adds 1.14 life year with versus chemotherapy alone, and 0.84 life years compared with atezolizumab. So to conclude the study, durvalumab plus chemotherapy is the new standard of care in first-line treatment of extensive stage small cell lung cancer. And durvalumab is the only drug which provides the flexibility of choosing cisplatin, carboplatin along with etoposide, and it has shown benefit in all subgroups, including brain metastasis subgroup. More than 17% of patients on durvalumab are surviving even after 3 years, showing long survival benefit. And it also provides a high response rate and demonstrated ongoing response at 2 years in thrice more patients than chemotherapy arm alone. And it is also convenient for physician to give durvalumab in maintenance phase as 4 weekly regime. And the safety finding remain consistent with known safety profile of durvalumab and chemotherapy. Thank you.